if you're too overwhelmed with occlusion as a pre-treatment phase, now we're in the aesthetic phase. So in the aesthetics, we have the golden ratio. I'm sure you heard about the term, the golden ratio, but Lombardi came up, nicely incorporated this golden ratio in the field of dentistry, the aesthetic smile. It doesn't necessarily mean we're supposed to mathematically scaling on every single tooth of the crown morphology, but at least it gives us great guiding reference, and this will give us a visual, it will definitely make the patient more visually appealing to start with. So I'd like to address some of the anatomy of the smile and some of the assessment criteria I perform for all of my full mouth reconstructive cases, so that you can also apply these to your patients. So I start with the facial midline, the glabellar tegmentum, to sort of analyze the symmetry of the nose, which is a critical factor for the aesthetics, and then the right and left sides, because sometimes the patient has discrepancies between those two. So I would start with the symmetry of the midline. And then you go on to the facial horizontal reference line. What I mean is interpupillary line, the commissural line, and if the patient opens his mouth, it will become the occlusal plane. So all of those lines in the realm of aesthetic dentistry, they should be parallel with the horizon and perpendicular to the midline of the face. So it may sound very basic, but this becomes critical piece of framework to have the successful aesthetic rehabilitation. And the facial third and the lip posture. If the patient lost vertical dimension, there will be a different appearance of those sections. And then, the lip posture, it should be competent looking type of lip posture. If it's a drooping shape of the posture, it could be the sign of the loss of vertical dimension. So such things you can go over. And as I briefly mentioned, the position of the lips at the vertical dimension, the rest position, and the incisal display of the maxillary centrals at the vertical dimension of the rest position as well. So male is approximately 1.9 millimeter, female like 3.4, and a more display, it means more youthful type of, appearance. And by the way, this case is not at the diagnostic phase. This is completed full arch implant rehab. Later, I'll show you, about this case, but because I had a good smile aesthetic for this, so I used this photo for the anatomy of the smile. But the anatomy of the smile assessment protocol, you should do both pre-treatment, post-treatment, and during any phase of your treatment of provisionalization until the definitive delivery of the prostheses. So the facial midline and interincisal midline, we need to see if they are coincidental together. And what we're looking for is the width and fullness and the symmetry, as I mentioned. A smile that is like at least half of the width of the face, it's aesthetic. And the position of the lip, the rest position, the lip mobility while smiling, they sort of dictate how much tooth structure and gingival tissue displaying. So some of the smile dynamics you can analyze with those positions. And the smile line. Sometimes, patient may have a reverse smile line or insufficient incisal display. So definitely, you should go over the smile line analysis. And ideal smile line means like coincidental, following the curvature of the lower lip while smiling, and the centrals slightly longer than the cuspids. And there may be a lot more criteria, but those are some of the basic the components for analyzing the smile. And the occlusal plane should be parallel to the interpupillary line. And it's important because we want to make our occlusal plane to parallel to the interpupillary line. And this is another case at the diagnostic phase. But sometimes many clinicians make mistakes. They align their eye level to the patient's eye level. And a lot of times it sort of misdirect our analysis, because it's a 3D dimensional and we have a space between the eye to the occlusal plane. It's quite significant. So if you align your eye level to the patient's eye level, a lot of times you miss, you may not necessarily catch up the proper assessment of the occlusal plane. So it's absolutely critical to align your eye level to the patient's occlusal plane to properly assess the parallelism between the interpupillary line to the occlusal plane. And one of the clinical tips I utilize myself is, especially when the patient has irregularities of the occlusal plane, you can align your eye level to the central incisor, and you keep slowly lowering down until you see the cusp of the bicuspids and the molars. And that's the level I stop and take a photograph. And if you look at the middle and the left photos, although it's a little small here, you can appreciate how much difference you can gain by angulating your eye level. So that's the thing I want to emphasize: align your eye level to the level of the occlusal plane so that you can properly assess the parallelism between those two. And in this case, there was a significant camp that when I pursued the next step of the provisionalization and prepping, I incorporated this information for my rehabilitation. And then we look at the profile view, the glabella, subnasal, menton. We can get the angulation of it and the Ricketts aesthetic plane, and followed by the nasolabial angle. The nasolabial angle is average about 100 degrees for the Caucasian male patients. And it really depends on the aesthetics, the ethnicity, and the patient's gender as well. And you may ask, why do we care about all these information? Is it too much? Well, these are good pieces of information for me for a reconstructive treatment. Since as we start the treatment, a lot of times we lose initial shape of the extraoral dynamic relationship. Therefore, it's great to preserve such recordings as a reference for diagnostic photos as comparison in the future. So I always, as a routine base, I take all those photographs and keep it on the file. And then while I'm moving on to the next stage, I always compare, and that dictates my direction of the treatment. And then we go on to the smile analysis. As you all may know, different levels of the smile: repose, low smile, high smile, the incisal display, gingival display, even the buccal corridor. And by applying all those, the assessment, diagnostic piece of information, we can then move on to our next stage, which is directing into the final goal of definitive prosthesis. Because if you don't do those analysis of the aesthetic smile, there's no way you can reach to the point where you can, have a successful aesthetic rehabilitation. So I think it's critical to do those systematic analysis in order to put yourself into the right direction. And some of the intraoral aspects of the zenith line. The gingival zenith point is defined as the most apical point of the gingival tissues along the long axis of the tooth. And you can evaluate this for the aesthetic analysis, a lot of times the periodontal assessment. But we can also use this for the supraeruption of the teeth. Remember the Turner and Miserian classification of the worn down dentitions? We at the same time, we look at the worn down dentition sign on the interior, but we can also evaluate the level of the gingival zenith line to see if there was any supraeruption. So those are kinds of thinking process that you can apply with other components of the assessment. And the smile analysis, keep going with the smile analysis with the reverse curve of smile. In this case, some people may say he has a reasonable smile, but if you don't catch that reverse curve of smile, you're not going to rehabilitate this case, and then you may not necessarily understand the patient's, the shift complaint properly. And then, we can fix this by having the proper aesthetic line on the lip contour. What about the midline? It's well known that the midline discrepancies are not easily noticeable. What I mean is as a displacement type of midline, off midline, we can't really recognize it. I mean, in this photo, I put a line in between those two so you can appreciate the difference. But if you look at those cases on the clinic chair as a daily basis, it's quite challenging to recognize the midline discrepancies. But the angular discrepancies is a lot more perceptible. And in this case, is quite, the excessive angular discrepancy. But even if it's angular, is a small angular discrepancy, even dentists or non-dentists, they can recognize it. So again, in order to lead into the right direction of the treatment, you should be able to analyze all those components of the midline displacement and angular discrepancies so that you can perform the right treatment for the patient in terms of analyzing proper aesthetics. You can dissecting the proper analysis, and followed by the ideal treatment delivery of the final processes. So some of the landmarks for the smile analysis would be the nose, forehead. You can use as many extraoral references, interpupillary line, philtrum, and the chin. And going to the intraoral evaluation for the smile analysis, you can also check up with the axial inclination of the teeth. This can be a critical piece of information if you're doing wax up yourself, or you're instructing the lab technician to do a virtual wax up, and going to the final direction of the processes. Because a lot of times in the aesthetic area, if you don't have axial inclination, from my experience, the patient's smile may not be as satisfying. So I always try to emphasize the axial inclination within the range of a non-traumatic. It shouldn't affect the angulation on the palatal, but on the buccal aspect, we have proper thickness, and so that we can play around with this axial inclination, which is one of the critical factors in the aesthetics, in my opinion, along with the aesthetic smile. And we look at the buccal corridor. The buccal corridor is the space between the buccal, between the cheek and the buccal surface of the posterior teeth. So, it used to be like a Hollywood smile in California. They tried to intentionally make the buccal corridor. But in my opinion, understanding the buccal corridor is also critical. So if you don't know that aspect at the beginning, then again, you can't really treat this patient with picturing the final look. So this patient is in the temporary phase. It's a full mouth maxillomandibular prep and temp case. So, and then we deliver the middle temporary here. So again, the fullness of the smile is critical. And the type of smiles, depending on the lip position, we have a low smile. Also, we have average smile and a high smile, as well as a gummy smile. So different levels of lip posture, and we should understand the dynamic relationship with the lip, as well as the tooth display and the gum display, so that when you're treating these cases, when you're doing wax up or the mock-up try-in, you have such things to look up for. You're not just doing the mock-up and then it looks, asking patient, are you happy? And then, moving on to the next step. It may be a good start point to start, but along the line, you need to have more comprehensive understanding and an assessment checklist to give more thorough treatment to the patient. So for me, if we are increasing vertical dimension, a lot of times we create the loosey jig, or we can use a light triad in the interior to increase the vertical. And you go over all those vertical dimension assessment that I previously discussed. And, and then once we have that established vertical, because it's quite amazing, if you have those cases, you can try out yourself. It's quite amazing to see how the lip dynamic changes with the different levels of the vertical dimension, also different skeletal classifications, or the thickness of the buccal contouring. It affects the millimeter the millimeter distance of the smile. It sort of gives us a micro fine tuning of the patient's smile with all those changing dynamics. So what I routinely or occasionally do is, when I increase the vertical dimension at the very first visit, I can create this triad, and then make a putty or bulk out the on the buccal aspect, and I let the patient smile. And in that way, you can evaluate and you can fine tune. You can grind it, and then you can fine tune the level of the smile that you want to establish with the patient. And then this information will give a critical connecting communication tool, with the lab technician when they do the wax up. And now we have a DSD concept where I will show you one of my cases with the DSD. We have amazing technology with the scanning, facial scanners and all that. But again, going into the foundation is critical. We have better technology every day, and it's great. You can utilize them, but knowing those dynamic relationship of the lip with the different thickness of the buccal contour, the level of the vertical dimension, I think it's valuable to have that in your mindset. And when the patient presents to you, let's say for the implant rehabilitation, so for this case, if you remember the patient with the failing implants on the maxilla, that I had to plan for the explantation followed by proper planning. Before we begin anything, it's absolutely critical to evaluate the patient's smile in reference to the gum, the gum line. And of course, we have a classification for that. The BIDRA came up with a different classification according to, in reference to the prosthetic tissue junction, the pink portion of the prostheses, how much space we have and the correlation with the different level of the smile line. And it's absolutely critical to have this in your head in order to plan out your next stage of the smile analysis, along with the implant therapy, the implant rehabilitation treatment plan. So in this case, the gum line, you can barely see some of the incisal edge, the trajectory gingival margin area. You see the gummy, you slightly see the gum line. And what it tells us is probably, this category will be, class 3 type of BIDRA classification. And why is it important? Because if we don't do the alveolectomy or alveoplasty during the surgery, and then we pursue like class 4 type of prostheses, the patient will see the prosthetic tissue junction, and it will be the aesthetic catastrophe. It will be a disaster for the rehabilitation such cases. So probably, and actually I did this case with a class 3 type of rehabilitation where we didn't use any of the pink portion of the prostheses. And if the patient has the level of the bone level about this much and the maximum smiling, then I would probably go with the class 4 type of treatment. And BIDRA came up with interesting paper as well. When the patient closes their eyes, the patient tends to smile more. And it's interesting. He did the presentation when I was a resident, and I think we did some of the seminar at the Tufts Dental School, and he presented that, and I thought it would be very cool. And I actually tried with my patient. It does change the dynamic of the smile. The patient tends to smile more. So, in the setting of the full mouth implant rehabilitation, like a hybrid, a fixed complete denture, it's absolutely critical to extend the patient's smile, sort of exaggerating the lip posture. Because unless we know the maximum ending of the lip, we can't really, have a successful reconstruction. It may lead to some of the aesthetic disaster. So rule number 6 would be evaluating the anatomy of the current smile and the new trajectory aesthetic plan. So when the patient comes and you evaluate the occlusal anatomy, the analysis, and you should think about once you attain the diagnostic cast, whether you go for the conventional or scan it, you need to think about how you're going to mount your cast, and that's the very initial start point, which is important. And the bottom line is we can use the patient MIP as a hand articulating if the patient has sufficient posterior the interdigitation on the posterior side. Then I would use a hand articulation because that's probably the most accurate reference. If the patient has lost the posterior teeth, we have no reference. And another case I showed you, the collapsed vertical worn down additions, we had to use the anterior jig to increase the vertical. In such case, I will use the CR position, centric relation. And I'm sure you heard about this term a lot of times, especially your prosthodontic residents or soon-to-be pros residents. Centric relation is a terminology where where our condyle is most anterior superior position with the most repeatable rotational position. So in order to attain this rotational cue of the centric relation, we should perform the deprogramming the muscle, the masticatory muscles. They should be free to go, and then you can perform this centric relation position in a repeatable position. Some of the interesting points would be CR, centric relation, does not necessarily coincide with MIP. And surprisingly, it's about 90% of the population. And therefore, the precision of the position of the capture is more important than the real position of the CR. So what I mean is, the patient, when we are capturing the bite, including myself, when you're putting yourself into the CR and slowly close down, due to the arc of closure and the anatomy of the posterior teeth, inevitably we have the premature contact. And whether it's a traumatic or not, it will be depending on how much teeth surface we have at the end of our, the mandibular movement. So if we're rehabilitating single unit or, 1 or 2 crowns, and the patient has MIP surface contact, I would hand articulate and rehabilitate as it is. If the patient needs a severe deflective occlusion or interferences, and we're rehabilitating more than like a 3 or 4 as a bridge or multi-unit restorations or even full mouth, then I would like to reference with a CR to capture the bite, because that's the most repeatable, most comfortable position for the patient, so that we can minimize any potential deterioration of the future processes. So same case over here, when the patient presented complete collapsed vertical, and then I use a Lucia jig technique here. You can use a leaf gauge if you have in the practice. I use a leaf gauge for occlusal guard, all of my occlusal guard cases, because it's easy to use. But for this case, we can't really use it because the patient's missing the anterior incisors. So we couldn't really use it anyways. So I utilize the Lucia jig technique with autopolymerizing resin, and then let it set and have a stable occlusal vertical stop on the anterior. And then for this case, I did the scanning, the upper and lower scanning, and then I completely moving on with the digital workflow. But if you're doing conventional, you can use some of the silicone bite registrations on the posterior, and then you can articulate the cast together. So for the CR-centric relation recording, there are different methods for the CR recording, like a static recording that I showed you, whether autopolymerizing resin or bite registration, exobite silicone type of bite registrations. And we have graphic recordings like pantograph, KDX tracing of the TMJ, Cobalt balancer, functional record. You can ask the patient swallow with the compound cones, and the stereograph cephalometrics as well. So different types of recording, and then a lot of times, as a reconstructive dentist, or we utilize the static method. And there's a study, a contour study, that's showing the accuracy of each static method. I'm sure you heard about the bimanual manipulation by Peter Dawson, and that's the most accurate. And we usually utilize this for the denture CR, for taking the CR on the edentulous cases. And a lot of times we use a chin point with the anterior jig, which is pretty much the same accuracy with the bimanual manipulation. So I prefer to use a chin point with the anterior jig on the fixed rehab cases, partially because I can save it and then utilize it whenever I want to precisely go back to the position that I captured. And then I can even use for visualizing the posterior disclusion, and then having the repeatable position back as a precisely that's the beauty of the utilizing the Lucia jig. And we have a swallowing and chin point guidance techniques, which is slightly less accurate than the other. So I would definitely utilize the Lucia jig technique for capturing the bite of the full mouth rehab cases. And type of material that we need to use for the bite registration, it should be completely, it should be accurate, and then dimensionally very stable once it's set, durable. It should be that soft consistency prior to the setting, and then once it's set, it should be rigid enough so that we can utilize this for our bite registration, whether diagnostic or your cross mounting for the later. And most important part of the bite registration I would like to address is the verification. You can verify your bite in several other methods, like intraoral verifications, venograph, and then some of the other, like split cast if you're using Artex articulators, semi-adjustable articulators. But I think the most important thing is intraoral verification, because you can do it right away. Just like denture CR capture with Allowax, you can verify your bite. That verification is critical, because we can take the bite registration a lot of times, but without the verification, I wouldn't trust my bite registration. So I absolutely go over the verification right after my registration. What I do is I cut the occlusal surfaces, the deep occlusal surfaces, so that I can prevent any unnecessary arc of closure, preventing the passivity of the bioregistration, and then passively sit the bioregistration as the patient slowly bite down. And that will sort of generate our future occlusal rehabilitation. That will be the starting point. That will be the reference for our next movement, next action plans for our rehabilitation. So it's absolutely critical, verify intraorally. And the articulators, some reconstructive dentists these days, they just do the digital workflow and then you don't really use the articulator. But it's valuable to know the concept and foundation behind it so that you know what it is. So the articulator, the purpose is, the most important purpose is the accurate orientation of the cast in reference to the plane of occlusion and type of articulator you're using, different Facebows. They have slight different the concepts, but later I will elaborate. But we have, by having the correct articulation, we have the posterior anterior controls of the guidances as well. So the Salenza articulator classification is the most common classification we go for, and a lot of times we use the semi-adjustable articulator in the class type B, where we can take both lateral and the protrusive records, and this is sort of simulating the condylar path by using average values. And class 4 is, we take all 3D dimensional dynamic registration. We call it fully adjustable articulator. And we can use the semi-adjustable articulator for, any type of rehabilitating cases, unless the patient has any TMJ disease or severe, issue with opening and some of the TMJ diseases, because the semi-adjustable articulator has average values. It has a sagittal condyle inclination, like a Bennett angle, protrusion, retrusion, immediate side shift, distraction, centric design, everything. It has, it has a built-in, ready to go type of, values inside. And of course, with some of the limitations, like, we're using the arbitrary hinge axis for the Facebow, and we don't utilize like a Fisher angle, immediate side shift. We don't have a timing, we don't have, if you're taking lateral tristic record, we don't have a timing of the eccentric movement. So we have certain limitations, but at the end of the day, most of the time, our rehabilitation goal is a mutually protected occlusion. So, why am I emphasizing this? Because we can do such programming on the semi-adjustable articulator so that, we can minimize any potential error. So my protocol of utilizing semi-adjustable articulator would be, we can record my jaw relation at the, if you're increasing vertical dimension, we can take the jaw relation at the desired vertical dimension, and then, taking several protrusive bites, and then, sort of evaluate on the articulator, average them out, and we perform the negative error, for the horizontal condyle inclination, and then we can test that mutually protected occlusion, whether wax up or interim restorations, and then we can use a custom guide table in the front. If you see on the tip of the articulator over here, you see the red pattern resin. That's the custom incisal guide table, where we establish the mutually protected occlusion through the interim or wax up. We can fabricate the interim, the incisal guide table, so that we can preserve the occlusal anatomy of the dynamic relationship, so that the lab technician later can utilize this for doing the wax up for final processes. So by having this flexibility of adjustments, we can use a semi-adjustable. But when are we using fully adjustable articulators? When the entire occlusion is reconstructed, and when the patient is suffering from occlusal and TMJ issues, and when the patient has severe immediate side shift. And in order to use a fully adjustable articulator, we need to use such called the KDX pantograph tracing, which is tracing the condylar, the TMJ directions, and it can give us the graphical information so that we can have a numerical information to put into the fully adjustable articulator, so that we have a full understanding of the patient's TMJ movement along with the occlusal anatomy, so that we can precisely design the shape of the occlusal anatomy. But again, in the realistic setting of our full mouth reconstructions, we are not creating bilateral balance occlusion for our full mouth rehab cases. We are creating mutually protected occlusion where we're generating the immediate disocclusion of the canine and protective guidance. So we don't need those detailed level of the occlusal anatomy, but sometimes we may need to have those informations. And then one of the important thing would be if you're using the KDX or pantograph, you can still use it with a semi-adjustable articulator, is you can use that as a diagnostic purposes for the any TMJ issues. So going to the Facebow, again, we're touching up the foundational part of the articulator and Facebow. It's developed by Snow, and it's really to orient the maxillary cast of the terminal hinge axis. And there are third point of references depending on the type of articulator you're using, and the axis of rotation. The arbitrary axis. We're using the ear bow as a reference. The most accurate, the arbitrary transfer is by the two condyles and infraorbital notch, and the majority of the articulator and the arbitrary hinge axis Facebows, they're utilizing this concept. And we have different arbitrary hinge axis about depending on different authors. We have different the views, but the important thing is, Weinberg did a study where as long as you're within the 5 millimeter of the true hinge axis, the anterior posterior error is only 0.2 millimeter at the second molar area if you're using 3 millimeter record thickness. So it's quite insignificant. And looking at the reference planes, depending on the articulator and the Facebow systems, you're utilizing different plane of occlusion, the reference plane. So why are we interested in this? Is later you will see the consequences of using different Facebow and the articulator in reference to the space that we will have on our mounted cast. So the tragus line, the Kemper's line, typical plane reference for our denture or full mouth rehab. And we have Frankfurt horizontal plane, the most on the right side. You can appreciate the reference plane is on the auriculo-orbital plane, it's the most inferior part of the orbital to the most superior part of the auriculotemporal reference. And this Frankfurt horizontal is parallel to the horizon when the patient is sitting up. So it gives a repeatable reference to the hinge axis. And in the middle, we have the patient's horizon. And I use RTAC CR articulator, the semi-adjustable articulator, and we're using the patient's horizontal, and you will see why. So if you transfer this information to the articulator, you can appreciate the occlusal plane that we have with the mounting cast is different. So you see how the patient's horizon, the maxillary and mandibular, imagine you have your cast, and then you're doing rehabilitation of the wax up or whatever, you have the space flexibility of both of the top and bottom. So that's why it's one of the most popular articulator and the reference plane system that we're utilizing, the patient's horizon with arbitrary hinge axis. We may not necessarily know this, but we may not necessarily apply this to our patient treatment, but knowing these type of foundation, you know how the articulator works, how the reference plane is coming from, it's a critical piece of information. And the occlusal plane, how do we decide the occlusal plane? We mount the cast, we reference planes, we properly articulate on our articulators, whether it's digital or conventional, and you decide the aesthetics and phonetics from the anterior teeth and spine line as a guidance. And the posterior occlusal plane developed by some of the tragus Kemper's line, or sometimes you can utilize the the retromolar pad area if you don't have any reference to start with. And remember the ridge parallelism and all those concepts. It can be also auxiliary type of reference to decide our occlusal plane. So you have your diagnostic cast, and you mount it. You're about to mount it, and you mounted your cast, whether CR or MIP. And how are we going to program our articulator? Well, I personally take the several the eccentric bites, like a protrusive record, the lateral protrusive record, along with the CR record, all of my cases. because we may pursue like some of the occlusal splint therapy, or I would like to analyze and to verify my CR bite registration, the articulation of the cast with those bite that I have, assuming the patient has no premature centric context. And if you're looking at the articulator, this is the semi-adjustable articulator. You can do the programming so that you don't need to use the fully adjustable articulators. And as I briefly mentioned, we can still use the lateral record, but it doesn't give us the timing information of the eccentric movement. So that's why we may pursue utilizing the pantographic tracing, the KDX, for the setting of the fully adjustable articulators. But again, we are generating mutually protected occlusion in about 99% of our cases of form of reconstruction. So we don't really need those armamentarium. And the overcompensation, undercompensation is an important concept because Hobo and the Gouchet, they came up with about 10 degrees of the reducing condyle inclination, so that if the angle is the condyle inclination angle is underestimated or measure less on the articulator than the real patient. So the resulting occlusion in the future will have so-called negative error, and where the articulator overcompensates for the mandibular movement. Therefore, the teeth disocclude more freely when the mandible moves. So if you imagine if you're doing denture, it's the opposite. We would like to have more contact on the teeth. So we would like to preserve the positive error. So those are overcompensation, undercompensation concept that we typically apply when we're utilizing the articulator. And as I mentioned, the incisal guide table, this will be the critical armamentarium to preserve whatever the mutually protected occlusion we achieved and during the intern phase. We want to transfer, or with the WAXA, we want to transfer to our definitive processes. It should be harmony with the posterior determinants, and during protrusion, it overrides the posterior determinants. And both anterior tooth position, condyle border movement must be considered in development of this anterior guidance. So as you can see, you can appreciate there is a directional pattern on top of this, the jig. So the rule number 7 would be mounting the diagnostic cast, either MIP or CR, with a Facebow, followed by programming an articulator, whether you're using conventional or digital.